Okay, so today what I'm going to do is I'm just going to talk about a case that I saw and I've been following for the last maybe 4 or 5 months. I just want to walk everyone through as to what we do and how we plan when we see a challenging patient with uncontrolled diabetes. So and then I will give you some information as to why we are doing what we're doing. So just to walk you through my thinking process when I'm seeing a patient with uncontrolled diabetes. So we can change it to the next slide. So this first, this is we all, I'm sure you've been taking history from diabetes patients for a very long time, but this is what I think about when I'm seeing a diabetes patient in a limited span of time. We can gather a lot of information, but this is what I really want to know about the patient's diabetes. When was his or her diabetes diagnosed? How was it diagnosed? Was the patient symptomatic, like polyuria, polydipsia at the time? Was he gaining weight or losing weight prior to the diagnosis? Meaning it was because the diabetes started after the weight gain, or is it like a type 1 diabetes? The patient was losing weight prior to the diagnosis. How high was the A1C at the time of diagnosis? And I'll tell you why I'm interested in asking all these questions. Some patients do remember their blood sugars, especially if they're very high at the time of diagnosis, like if they presented with hyperglycemic hyperosmolar syndrome and it was reading high. So that's also important information. What was the first treatment that was started for them? Was it metformin? Was it insulin from the start? So that is also important information in going forward. And if they have a diabetes diagnosis for a long period of time, when was the insulin started? How long into their disease was the insulin eventually introduced? Ever had DKA, diabetic ketoacidosis? Now type 2, especially uncontrolled, can also develop DKA. So that's important information as well. Any problems from their diabetes, end organ damage like neuropathy, microvascular problems, or macrovascular problems such as stroke and heart disease, and hypoglycemia, how often they are getting low blood sugars, and can they feel a low blood sugar coming on? And if they can, how low do they have to be before they can sense a low blood sugar? So these are some of the things that I always ask all the diabetes patients, especially on their first visit. We can change this line. So this patient that I'm going to talk about, he came in, he is about, I don't remember the exact age, but he's in his late 50s, early, touching 60s. And he was sent to me because of uncontrolled diabetes. And I will show him more information about him in the next few slides. But when I saw him in the clinic, he said that his A1Cs are running high and his doctor has sent him here to me so that I can yell at him, because the primary care physician is tired of yelling at him because his blood sugars are out of control. So, his diabetes was diagnosed in 2008. This was diagnosed during an acute hospitalization. He was hospitalized with acute chest pain, and at that time had coronary bypass grafting done during that admission. He does not recall gaining or losing weight prior to the diagnosis. His initial A1C, he remembered, was about 10.4. He was not sure about 10, the exact number, but he said it was more than 10, and eventually I got the records that it was 10.4. Because he was decompensated and he had the bypass surgery done, he was started on insulin as the initial treatment, along with metformin. He was discharged on metformin from the hospital as well, but then he developed diarrhea. Soon afterwards, he attributed it to metformin. This was stopped. Because of his heart disease history, sometime in 2013-14, he was started on Jardiance, which is an SGLT-2 inhibitors, and rightly so because of his heart disease history. However, he developed a yeast infection just once, and this medication was stopped. He does not recall ever have been diagnosed with diabetic ketoacidosis. He has macrovascular problem, meaning heart disease, and also he was complaining of some neuropathy, both autonomic, like erectile dysfunction, and sensory neuropathy. And he really cannot tell me if he's having low blood sugars because his blood sugars are always running high. So when I get this information, I know that in the initial presentation, he presented with macrovascular complications. So most likely, and with an A1C of 10.4. So most likely, his diabetes has been going on for a very long period of time. And most likely, the end organ damage had already started. And mostly, this is telling me that his pancreas were not in any position at the time of diagnosis to make and release insulin. As I said, he is prone to developing complications from hyperglycemia because in mid-50s, he had a coronary artery bypass grafting. So that is when I'm talking to him for the first 5 to 10 minutes, that's what I'm thinking about as to how severe his diabetes is. All right, next slide. So the second part, that when I am talking to the patient, I think I say to myself, and that's the information I want to gather as to what are the challenges this patient is facing, and as a provider, what are the challenges that I am facing in helping this patient. So that's the first thing. How often is this patient checking the blood sugars? That's very important, especially if they are on insulin. How often can they check their blood sugars consistently going forward? Can they give me 2 or 3 blood sugars as I'm especially changing the diabetes medications or insulin? How often is the patient missing insulin injections? This patient, I will tell you in the next slide, he was already on 4 injections every day. But how often is he really taking his injections, and how often he's missing them? So how consistent can we be? And I want to work with the patient in coming up with a plan that can work for him or her. If they cannot take 4 injections and I keep prescribing 4 injections, then I'm setting up for failure from the start. Diet, of course, is very important. Are they eating fast food? Are they on any diet? Are they interested in starting any diet? That's another thing that I want to know. And then most importantly, and that is something sometimes I see people forgetting about, is anything that is making their diabetes worse that we can address separately from the diet, from the insulin, like any steroid injections recently, any oral steroids, creams, gels, patches, suppositories. Those are some of the things that can increase the blood sugar. So I always ask my patients about these questions about the steroid or any chemotherapy. Most chemotherapeutic agents have steroids, especially for the first few days. So that's all. I always ask this question as well. Next. So when I asked him these questions, this is what he told me. He said that he's checking once a day at most, but he's only doing it like 4 to 5 times a week. So there are a few days in which he's not even checking his blood sugar. How often can he check his blood sugar? He said that he can check it at least once. He cannot promise that he can check it 2 times a day, but he'll try his best. He also mentioned that out of the 4 daily injections which was prescribed by the primary care physician, he was missing at least 2 injections every day, and sometimes 3 injections every day. So essentially he's taking 1, at most 2 injections out of the 4 injections. He's not on any diet. He is single, and he mostly eats breakfast and dinner. So he skips lunch, and mostly his dinner is fast food, and that's the biggest. His breakfast is also consisting of high carbohydrate intake, and also the dinner. So only 2 meals and high carbohydrate intake, and no steroids or any transfusions recently. Transfusions are important because if your patient has received any transfusion, then the A1C will look falsely low. And then A1C will be unreliable. We will only have to rely on the blood sugars. Next slide. So this is his data. If you see here, this is April from 2008, from last year. I saw him in March of this year. So if you look at all these labs, his blood sugars are always high, almost always high whenever they are checked. Now, I don't know if they are all fasting or he had eaten, but they are consistently high, 300 plus. His renal functions are fairly stable for someone with this kind of disease for so long. Sodium is, I think, falsely low because of the blood sugar. If we correct it, the sodium will be okay. Otherwise, he's all right. So the last lab that I have is from January, or I had at that time was from January, and his blood sugars were running high, kidney functions were decent. Similarly, the lipid profile, which I think is from uncontrolled diabetes or the lack of insulin, is showing that the triglycerides are in high range, and they really cannot calculate LDL reliably because of that. But when they did use the formula to calculate it, it was for a cardiac patient, it was a little higher than what we want him to be. And I think that is also from diabetes. One of the commonest things that you'll see in these diabetes patients, uncontrolled diabetic patients, is a low HDL or high density lipoprotein, and that is from the uncontrolled diabetes. So his labs are pretty consistent with his story, and and consistent with hyperglycemia as well. Next slide. So always I look back at the A1Cs and see what the trend of A1C is. And I have voluntarily masked these last two because as we progress into the case, I will explain as to what happened to him. So his A1C has been 11 plus throughout, ever since he was diagnosed, 14, 13. So he's consistently uncontrolled on insulin. He cannot take metformin because of the diarrhea. So he is supposed to be taking 4 injections. And this is how high he's running because he's most likely not taking most of the injections. Next slide. So this is what he was supposed to be on: Levemir, which is Determire insulin, 80 units daily in the morning, and then Novolog, 12 units before each meal. So those are his 4 injections. He's also on lisinopril, which he takes every day. He is on a statin, paravastatin. I think Paravacol was the medication that he was on, and rightly so with his heart disease and risk factors. He's on an aspirin as well as Plavix since his initial diagnosis of coronary artery disease. And his last eye exam was 14 months ago, and he was told at that time, and has never been told, that he has diabetic eye disease. So this was his regimen that he came to see me with. Next slide, please. Again, as I said before, he's missing most of his injections. There's sometimes 2, sometimes 3 injections on a regular basis. Next. So yeah, I want to highlight this point here. So if you see his basal insulin and bolus insulin, although he's not taking it, his total basal insulin is about 80 units, and his bolus insulin is 12 units before meals. Now he's only eating 2 meals, breakfast and lunch, breakfast and dinner. So if you see the ratio, the total basal insulin is 80 units and the total bolus insulin is only 24 units if he's taking all these injections. So the ratio is off. Ideally, it's depending on the carbohydrate intake, especially in someone who is eating outside and on large doses, on large carbohydrate meals, this ratio is off. So it's only 24 units of bolus insulin and 80 units of basal insulin if he is consistently taking his injections. So that is a common problem that we see in these patients. If the patients are eating high carbohydrate meals, then their bolus insulin should be close to their basal insulin as well. So that's one thing that I wanted to highlight in this regimen. Next slide. So what are our options? I'm seeing him in my office. He's sitting in front of me. Option number 1, his kidney functions are fine. Should we restart metformin? Now remember, some people are very sensitive about restarting metformin, especially if they had severe diarrhea. So I always want to sense how they feel about restarting metformin. I don't tell them just restart metformin. So that's the first thing that I have in mind. Can we start? Is he ready to start metformin? So that's one thing I have in mind. Next. Yeah. All right. What about the sulfonylurea? Can I give him? He's missing his injections. Can I just give him glimepiride or glipizide or glyburide? So that's the other thing. And I will discuss more of these, as we go along each of these options in detail. Next. Okay, what about SGLT-2 inhibitor, Jardiance, for example? He has cardiac history. Will it be a good option? So that's another thing I have in mind. Next, please. Sure, we need more blood sugars. How many blood times can he check his blood sugars? Next. Can I just tell him, look, I cannot do anything for you today. I need blood sugars first, so go home and send me blood sugars. I will not change anything today. So that's one of the options that we have. Next, please. Now, this is very important. When I'm treating these patients and they're running high, they're running into the 300s, I do not want their blood sugars to go down into the 100 to 150 immediately. My initial target for the next 2 to 3 weeks is a target blood sugar of 180 to 200. And that is to prevent relative hypoglycemia. If I give him a big dose initially and he drops into the 100 and start getting symptoms, most likely he's not going to continue with my treatment plan. And most likely he will not come and see me again because he felt symptomatic. Their body is used to living at a very high blood sugar. The autonomic nervous system has acclimatized to these numbers. And if I drop the blood sugars too fast, I'm putting patient at risk. And also most likely he's not going to stick to the plan. So target blood sugar, I tell them what targets I have in mind, depending on what blood sugar they're coming in with. Next, please. eye exam, and this is very important. Most of the times people will tell me that when the blood sugars are high, they get blurry vision. Now, I want them to see the eye doctor, but I do not want, I tell them, I want you to go and see, if the last visit was 14 months ago, I want you to go and see eye doctor, but please don't let them change your prescription glasses, because your eyesight will change once the blood sugars are improving or have improved. However, I still want them to go and see the eye doctor, because the eye disease can worsen as blood sugars improve. So the diabetic retinopathy can worsen because of the free oxygen radical formation. So eye exam is a must, but do not change your prescription. Do not let them change the prescription glasses until, or prescription number, until we control your blood sugars. Next, please. All right, so the other option is, what about using a DPP-4 inhibitor, such as Januvia or your saxagliptin, Tradjenta, those kind of medications, or in weekly GLP-1 inhibitors, which are your Ozempic and Trulicity and Bydureon. Can we use this to improve his blood sugars, because he's missing his injections? So those are some of the things that I have in mind, and I'll deal with one at a time. Next slide, please. Okay, so I said metformin. I'm not going to I'm going to ask him about restarting metformin, but when I talked to him about it, he said that he developed horrible diarrhea and he does not want to restart metformin just yet. Now, sometimes patients do well on extended release metformin, so that is always an option that I can offer to the patient. But when I talked to him about metformin, he said no, he does not want to restart metformin, and I said that's fine. Now, why not sulfonylurea? These are the glipizide and the glyburide. So this is the problem. Here, when the patients are diagnosed with diabetes, we know that their blood sugars are running high. If they are uncontrolled, their blood sugars are running high. Now, at the same time, this graph here represents the beta cell function. So this represents how about the potential of the pancreatic cells to release insulin. So by the time they're diagnosed with diabetes, most of them have lost about 50% to 30 to 50% of their pancreatic functions already. Now, this patient's A1C was around 10.4. He was uncontrolled, and he has been uncontrolled for a long time. So most likely in that patient, his pancreas is not making and releasing any insulin. Sulfonylureas work by increasing the release of insulin from the pancreas. So even if I give them a sulfonylurea, I should not expect any improvement in the blood sugars, because most likely his pancreas cannot release any insulin in response to a sulfonylurea. So is that an option? It is an option, but if I give him 4 milligram of glimepiride, I should not expect any improvement in his blood sugar. So I think I'm wasting his time and money by giving sulfonylurea in that situation. Now, if you're seeing a younger patient who is just diagnosed an A1C of maybe 7.5, that's a good option, because they still are here somewhere, and their pancreas actually can release some insulin. Especially if they lose weight and the insulin resistance goes down, this is an option, but not in patients like this. So we see these patients who are coming in, blood sugars are running high, 300, 400, and they're taking glipizide 20 milligrams a day. Is it doing anything for them? Most likely not. So that is not an option. If I see even if he was on sulfonylurea, I would have stopped it at that time, because most likely no benefit. All right, next slide. Okay, so why not SGLT-2 inhibitors? I said, and you all know this, the most SGLT2s, Jardiance, Farxiga, Invokana, most of them have actually good cardiac safety data for secondary prevention. So in patients who have cardiac disease, if we give them these medications, and if we give them for 3 years, almost 40 months, we can reduce, if we treat 40 patients, we can reduce 1 cardiac event. So these medications are good. They have a role in treating these diabetic patients. But if you look at this medication works on the kidney, on the nephron, and prevents the absorption of glucose. So basically, they are peeing all the glucose in that situation. Now, if his blood sugars are running 300 and 300 plus, and if I give them this medication and blocks the absorption, he's going to be peeing all the time. He's going to be peeing glucose all the time. The more glucose he'll pee initially, the more the chances of developing a yeast infection. So, and I think that's what happened to him. He was started on SGLT2 at some point, I think in 2011 and 13. His A1Cs, if you remember the slide before, they were 10 plus, 11 plus all the time. So he developed a yeast infection, not because of the medication, but because his blood sugars were so high, and it was just a disaster waiting to happen. Sometimes the fournier is gangrene, or the skin infection can also happen because of the same reason. So although SGLT2 is a very good option, but I will wait to bring his blood sugars down before I will consider adding SGLT2. At what level will I start it? Well, if his blood sugars are in the 160, 150 to 200 range, I think that's where we can safely start an SGLT2, but never with a blood sugar of 300 or 300 plus. So can we use it? I think we can, but not in the situation, not on first visit, not until we get the blood sugars down. Next slide, please. Now, this is just the A1C reduction with the different agents. So what about DPP-4? You know, these are your Januvia and Tradjenta. So this is the reduction that we expect after starting these medications. If you see here, this is almost maybe 0.7%. So if the A1C is running 13 and I give somebody DPP-4, I should expect it to come down to 12.5. Is that a major change? Absolutely not. We can do much more with intensifying, and this represents the insulin. The pink line here represents the insulin. So in this patient, in these decompensated patients, we should intensify insulin rather than trying these medications, especially the DPP-4. Now the weekly incretins, this is old data. Some of the newer incretins, especially Ozempic, which is semaglutide, has much better A1C reduction. So that will be an option, but again, mostly the insurances will not cover it if your blood A1Cs are more than 9%. So in his case, they were not going to cover it anyway. So our best bet will be to intensify insulin, because we can bring down the blood sugars to at least 2%, 2.5% in the first 6 months if we do that. So yeah, so that's the rationale for not using a DPP-4, maybe not using a TZT at that time on initial visit. Next slide, please. So best options. What are our options? Next, please. So again, I think we addressed that. Can you click so that I can see all the options? Yeah, more. We already talked about this. Yeah, click more. All right. So this is what we did. I think we have already talked about most of this. Should we start metformin? GFR is more than 60 in this patient. It's a very good option. I think it will be safe. However, the patient is not ready. I laid grounds initially. I said we will start a low dose. We will go slow. Mostly, I start metformin as 500 milligram at night for 1 week, and then go to 2 pills. And I use the extended release 500. I do not use the extended release 1000. It's more expensive. And do not use the regular metformin because it has more GI side effects. So I told him that, but I didn't start it during the first visit. Sulfonylurea, we already talked about. The pancreas are burned out. It's not going to help him. SGLT2, for example, Jardians. If I start him initially, yeast infections because of the high blood sugars. At some point, I will add that, but not during the first visit. So can we just tell him, go go home and start checking your blood sugars? Well, we can do that, but certainly we can offer something to this patient. Maybe if he's just taking it 2 times a day, from once a day, I can help him. I can make some changes. And again, my targets for these patients when they're uncontrolled is between 180 to 220 for the first 2 weeks. I do not want to see numbers in the 120s and the 130s because the relative hypoglycemia, their body is used to living in higher numbers. Again, I've already mentioned that we need an eye exam as soon as possible. I do not want them to change the prescription classes. However, the eye disease can get worse, and I do not want patients to develop blindness and retinal hemorrhage as I am controlling their blood sugars aggressively. DPP-4, the reduction is very small, and we can do better with insulin alone. Next slide, please. So that's what we decided. Can you click more so that we can, yeah. All right, very good. Okay, excellent. So this is what we decided after talking to the patient. I told him that I want blood sugars checked twice and at different times of the day. Can you check it in the morning, first fasting numbers, and at bedtime. And some days, especially when he's not working, I want blood sugars before lunch and before dinner. So although he's checking it 2 times a day, I will have an idea as to how the blood sugars are running throughout the day. So that's the first thing. And we decided that if he can give me blood sugars 2 times a day, I can really help him. Now, he was on 4 injections a day, 1 basal insulin of Levemir and 3, supposed to be on 3 bolus insulin, but he was missing most of these injections. In these patients, they can, because he was taking about 2 injections every day. So I talked to him about using the combination of NPH, which is a intermediate acting insulin, plus the regular insulin. So 1 injection will have both the bolus insulin as well as kind of a basal insulin as well. And we decided to use, so because of the regular insulin, this injection needs to be taken 30 minutes before breakfast and 30 minutes before dinner. So that's the insulin we decided to use. Now, because he was taking at least 80 units of of Levemir every day and 12 units of Novolog, he was missing the other 2 injections. So his total daily dose that he was taking was on average close to 100 units is what he was taking. So I said there that he's taking 100 units of insulin a day. However, his blood sugars are still running high. So we will use a ratio of 1:1 from conversion of Levemir into NPH. And also if he was even on Lentis, you would have used the same the ratio. But so what we decided was 60 units of NPH and R 30 minutes before breakfast. So a bigger dose in the morning, 2/3 of the total dose in the morning, and 40 units before dinner. And my target in the next few weeks is 180 to 220. When the patient left the clinic, I also gave him my email address, work email, so that he can send us his blood sugars on a weekly basis. And again, the target is, I want to keep him high. I just want him to get used to this insulin, consistently use this insulin, and then we will adjust blood sugars on a weekly basis. Now, if you see here, I started him on 100 units of total insulin, and about 30% or 30 units of that is R insulin, or the shorter acting insulin, and 70% is the basal insulin. So the ratio is still off, but he's still taking more bolus insulin than he was initially taking, because he was only taking 12 units of the Novolog once and was missing the 2 injections. So that's where we have a little bit more advantage with using these combinations insulins and pre-mixed insulins. Only 2 injections, the ratio is a little better. Now there is an NPH and R insulin that comes in the ratio of 50-50. So it's called NPH-R 50-50. So 50% of the total dose of 60 units will be R insulin, and the 50 will be NPH insulin. We can use that, but in his case, because he was only eating 2 meals, I said let's do 70-30. All right, next slide. And hypoglycemia precautions, especially if he's at risk for developing relative hypoglycemia. Next slide. Okay, so, and this is important so this light blue line here represents the NPH insulin. So and this represents the 24 hours. So when we give patients NPH injection, it lasts for about maybe 10 to 12 hours, and then the levels start to wean off. Therefore, when we are using NPH insulin, it's always a good idea, unless they have significant kidney disease, to use it 2 times a day. So in this patient, we decided to use it before breakfast, so around here, and then before dinner as well, along with the regular insulin. And when we compare this to the Levemir insulin is slightly different, and once a day should be okay. And Lentis, as we know, is a true basal insulin, and this will last 24 hours. But NPH is not the same. We have to split the dose into 2 injections with the NPH, and if we can mix it with the pre-mixed insulin, that also helps. Next slide, please. All right, so this is this patient. I saw him in March, right here, and his last A1C was 14. So I saw him in March. I think it was middle of March when I saw him, and I said, well, this is our target, this is our plan. This was an A1C repeated by his primary care physician. So the plan was, we started doing this insulin in March. So the A1C is not truly reflective of the 3 months on the treatment plan, but it started coming down, 9.8. So I think this was still affected by the higher A1Cs before. And this is his message to us, to the clinic, that he said that his morning blood sugars are running between 140 to 250, and dinner is between 106 to 260, depending on what he's eating. And he feels that his blood sugars are improving, and this was our actually reply to him. So again, this is I think this was 2 to 3 weeks after my last appointment. So he's improving some, he's at least following the plan, he's happy with 2 injections. So we are making some progress by actually reducing the injection burden for this patient. Next slide. So he came and saw me in May. He had gained some weight, which is a good sign because now he's not peeing all those calories, all the glucose that he was having before. So he has gained weight, and I think weight gain when the patient starts insulin is a good sign because now the patient is not losing calories. He reports more energy and some improvement in nocturia. He's not getting up 2 to 3 times at night, maybe just once. At that time, I told him that I'm going to add metformin, extended release. And I told him that if he develops diarrhea, then we will stop. But we're going to start at 500 at bedtime and then go to 2 pills after a week. And in that situation, I also recommended starting a GLP-1 analog, which is Ozempic or the semaglutide. And the reason for choosing this agent is twofold. Number one, it helps suppress the appetite. And also it has cardiac benefit for secondary prevention for diabetic patients because it prevents a major cardiovascular event. And we normally start this agent at the lowest possible dose, 0.25 weekly, and then increase it to 0.5, which is the medium dose after 4 weeks. If you are giving this agent, their appetite will improve, meaning their appetite will decrease, they will be eating less, and also they will feel full faster. So there is a chance that we will have to reduce the insulin at that time. And that's what I told him. I said, look, if your blood sugar starts running low, you can go down to, depending on how low you're running, from 60 to maybe 45 units. And similarly, before dinner, if you're noticing major changes in your appetite, then we will make the reductions. And he had not seen an eye doctor till then. And I again re-emphasize, because again, as the A1C is improving, there is a chance for the diabetic eye disease to get worse, and the bleeding to get worse. So I always tell my patients that the A1C starts improving, blood sugars are improving, that's something that can go wrong. The bleeding in the eyes can actually get worse. So he absolutely needs to go and see the eye doctor. Next slide. Okay, so fast forward, I saw him in March. In May, he's 9.8. A1C has come down, and most recently, his A1C is now 6.3%. So it has gone down from 14 to 6.3. No blood transfusion. This is a true A1C number. At that time, when I saw him just recently, I added an SGLT-2 Jardiance, because now I'm not worried about him developing a yeast infection because his blood sugars are in good range. They were running, I think most of the numbers were between 160 or 120 to 160. There were some outliers, high numbers depending on what he was eating. He had already seen a dietitian and he was reducing his carbohydrates. He was motivated. He wanted to lose weight. When he saw the eye doctor, they did notice some proliferative diabetic retinopathy, which was mild. And most likely that happened because of the acute drop in the A1C. But no laser treatment, no injections. The eye doctors want to repeat the fundoscopy, dilated eye exam again in 6 months to make sure it's stable. I intensified his statin, blood pressure control, and he's on aspirin and Plavix like he was before. And his current regimen is he's taking only 40 to 45 units in the morning, depending on how much carbs. If he's eating a large carbohydrate meal, he will take 45. If he's eating a low carbohydrate meal of N and R, only 40 units. And similarly, at dinner time, he's only taking about 20 to 28 units. If he's eating fast food, he will take 28. Otherwise, he'll take 20 units. So insulin has gone down, his A1C is improving. And now, most importantly, other than the numbers, he is on medications which are important and beneficial for his heart muscles, SGLT-2 and the GLP-1. Both of them, as I said, if we keep these medications for 3 years, we can actually reduce one acute cardiovascular event as a secondary prevention. So he's on both of these medications. Next slide, please. All right, well, that's it. Yeah, so that's a kind of a thought process that we have when we are seeing these patients. We just don't want to treat the number. We want to help prevent events, cardiovascular events, and stroke events. And this is, we want to work with the patient, come up with a plan that will work for them. And that can mean just reducing the injection burden as well.
Awesome. Thank you so much, Dr. Heider. That was wonderful. Does anybody have any questions about this? I'm sure you're all still processing. You're welcome to email me those questions if you have any afterward, but you're also welcome to ask them now.
So I have a question. This is Jennifer Boyd. I think you said this, but I didn't catch it. The basal to bolus ratio, should that be 1:1 or?
Well, yeah, good question. So basal to bolus ratio, it depends on how many meals they're eating and what they're eating. In an ideal setting, if the patient is obese and has significant insulin resistance, absolutely, it should be 1:1. Okay. But there are patients who are working and skipping a meal. So in that situation, it becomes a little tricky if you want to divide 50% of the insulin in 2 doses, because that will lead to hypoglycemia. In that situation, 70-30 or a 60-40 basal bolus ratio should be okay. So again, how many meals they are eating, number one, and how much insulin resistance they have.
Okay. That was really a great presentation. Thank you so much. To me, it explained actually a lot of things that are on the echo case form that I never really was sure why they were there. So that's really great.